We are going to discuss on the last type of microcytic anemia in this video, that is thalassemia. So this itself needs a separate discussion per se, because this is really a huge topic, because you have to understand a lot of genetics behind this thalassemia. That's why. So if you ask about the why thalassemia causes microcytic anemia, again we go back to the basics. The reason is I told you because of reduced globin synthesis. Again the same thing which you have discussed innumerable times, heme and globin is going to result in something called hemoglobin. I already told you either heme synthesis reduction, or if there is reduction in the globin chain synthesis, your net effect is going to be reduced hemoglobin in the cytosol. If your hemoglobin production in the cytosol is reduced, you are going to result in a microcytic anemia. So thalassemia comes under this area where the globin chain synthesis will be reduced. Because of that, you will have a reduced hemoglobin synthesis and you will have something called a microcytic anemia. So that is the reason. So anyway, so knowing the basics and going to like in depth is always important. So once you move on from this, the most important thing to understand thalassemia is the like basic differences between an alpha and a beta thalassemia. So what is going to be an alpha thalassemia and what is going to be the difference in a beta thalassemia? So in alpha thalassemia, the problem is the synthesis of the alpha chains, and beta thalassemia, the problem is the synthesis of the beta chains. You know that. We are not going to discuss anything more than that. But what are the, in general, what are the basic differences? First thing, if you ask me about the geographical differences, alpha thalassemia is very common in the Southeast Asia and Africa, geography wise, whereas beta thalassemia is also very common in the Mediterranean regions. That is the reason why beta thalassemias are also referred to as something called a Mediterranean anemia. Then you have something called a genetics. Genetics, generally alpha thalassemia is due to gene deletions. Alpha thalassemia is due to gene deletions very commonly, but there are a lot of other types, other genetic reasons why you get an alpha thalassemia as well. But gene deletions are the classical and the most common. But if you ask me about beta thalassemia, they are generally due to point mutations or frame shift mutations. So that is the reason why you get a beta thalassemia commonly. Then whether they can present in fetal life or not. Fetal life, can they present? I am not telling all thalassemias present on fetal life, but if few do present in fetal life, but if they do present, can alpha thalassemia present in fetal life? Yes, certain types. Especially only one thing that will present in fetal life is that for all 4 gene deletion of alpha thalassemia, which we will discuss in some time. So, but yes, still it can present. But if you ask me whether beta thalassemia can present fetal life or not, answer is no. They can't present in fetal life, absolutely not possible. The reason why they can't present in fetal life is because there are 2 hemoglobins. In fetal life, what you need is HbF in fetal life, and you need HbA in adult life. If you ask me what do you mean by HbF, it will be alpha 2 and gamma 2 chains. If you ask me what about your HbA, it is nothing but alpha 2 and beta 2 chain. So this is what we call adult hemoglobin HbA. But one thing you can commonly notice is that both HbF as well as HbA needs alpha chains. So which means alpha thalassemia, if it's sufficiently severe enough, it can cause problems in both fetus as well as adult. But your HbA, since your beta chains are formed only in adult life, it is not important in fetal life. In fetal life, your beta chains are not important, which means initially the gamma chains will be the one that is predominant. Alpha will be there in both adult as well as fetus. This gamma becoming beta is complete by around 6 months of, 30 weeks of postnatal life. That is around 6 months of postnatal period. That is approximately 6 months postnatal or 30 weeks postnatal. That is the time where your gamma chain shift to beta chain will happen. That is the time where your HbF will be completely taken over by HbA. So that is the idea. So that is the reason why alpha thalassemias can happen in fetus as well as adult life, but beta thalassemias can happen only after birth. That is, it can happen only 6 months after your child is born. So that then only you can have a clinical manifestations from a beta thalassemia. So that is a very important thing to understand. But before that, what is the problem in this alpha and beta thalassemia? What is the pathophysiology in alpha and beta thalassemia? What could be the reasons for why you get an alpha and beta thalassemia? reasons for the clinical manifestations. The reason is very simple. Suppose if you take it's a overproduction of, relative excess of the other normal chain that is being produced. For example, if you take an alpha thalassemia, the alpha chains are reduced in number, whereas beta chains are normal, which means even though it is normal, in this context is relatively increased. So which means the beta chains tend to precipitate and they are going to result in something called erythrocyte instability. They are going to result in something called erythrocyte instability, which will result in hemolysis and ineffective erythropoiesis. Hemolysis and ineffective erythropoiesis. So that's what is going to result from this. If you have a beta thalassemia for that matters, what you're going to get is your alpha chains will be normal, but the beta chain production will be significantly decreased, which means here your alpha chains are in relative excess. So these alpha chains can precipitate. Here the beta chains are precipitating, but here the alpha chains are precipitating in a beta thalassemia. Because of that same reason, you will get erythrocyte instability and ineffective erythropoiesis and anemia because of that. So which means in both alpha and beta thalassemia, the problem is in the relative excess of the normal chain. Relative excess of normally produced chains. That is the problem. So that is the reason why you get the erythrocyte instability and hemolysis. That is also one reason. For example, if you take a beta thalassemia, if you have an associated alpha gene deletion, for example, if alpha is also decreased in a patient with a beta thalassemia, so the patient is having already a beta thalassemia, the patient is having associated alpha gene deletions. What you are actually doing is you are balancing the alpha beta ratio, which means you are putting the ratio of approximately you are making the ratio to 1. So which means this might result in less severity, which means coexistence of alpha gene deletion or an alpha thalassemia with a beta thalassemia is actually beneficial. Even though you might think it's not good, beta and alpha both together, no, it's actually good because the instability will reduce, because the chain imbalance will reduce if they both coexist together. That is also one reason why you have to understand, because in the future I'm going to discuss about those things also. So now this is the pathophysiology of alpha and beta thalassemia. Once you have noted about the pathophysiology, pathogenesis of alpha and beta thalassemia, you have to know about the classification. So how can you classify alpha and beta thalassemia? So classification wise, if you ask about alpha and beta thalassemia, I can do two things. One is the clinical classification and second is the genetic classification. If you ask me about the clinical classification, clinically there are three types. One is severe forms, and second one you have something called intermediate forms, and third one you have something called mild forms or minor forms. That's what we call. Severe forms, there are only two types. In an alpha thalassemia, there is a disease called hydrops fetalis. Hydrops fetalis. Typically, we are going to discuss in detail about all these things in the genetic classification, but still I am just giving an overview. Where the fetus will die at the fetal life itself, which means it's a death in utero. It's not going to survive. It's not going to see the world in any way. So this is what we refer to as death in utero. This is generally due to the all four alpha gene deletions. Only 4 genes are there totally in a human being. So all 4 genes are related. You will result in this fatal condition. The second one, in a beta thalassemia, you have something called a thalassemia major. Thalassemia major. So this is otherwise referred to as something called a Cooley's anemia. Cooley's anemia. So what do you mean by thalassemia major? The moment you call it thalassemia major, we call this as actually transfusion dependent thalassemia, or TDT, or otherwise you can call it as a transfusion dependent thalassemia, which means in this patients the anemia is so severe that the patients need lifelong transfusions, regular transfusions throughout their life, otherwise they won't survive. So that's why this is what also referred to as something called a transfusion dependent thalassemia. This transfusion dependency is the key to diagnose this thalassemia major clinically. So this is the key. So without this you cannot diagnose a thalassemia major. That is the key for branding a patient as a thalassemia major. Otherwise you can't tell the patient as a thalassemia major. So intermediate, only one thing is there. Typically we tend to call them as something called a thalassemia intermedia. thalassemia intermedia. So what do you mean by thalassemia intermedia? So there are a lot of overlaps between the thalassemia major and the thalassemia intermedia. If you ask me, there will be too much of overlap in the clinical features. Overlap in the clinical features will be there. So there are a lot of things which are more common in thalassemia major than thalassemia intermedia. There are a lot of things which are more common in thalassemia intermedia than thalassemia major. But what differentiates intermedia from major? Which means the clinical features can't differentiate. Which means whatever clinical features I'm going to tell in the future can be seen in both thalassemia major as well as thalassemia intermedia. So we can't differentiate based on the clinical features. But what typically differentiates is thalassemia intermedia is non-transfusion dependent thalassemia, which means they are not dependent on any regular transfusion. So which means you don't need any regular transfusion in this patient, which means their anemia is not that severe. At the same time, they tend to manage with occasional transfusions only, which means occasionally whenever the patient is going for some stressful conditions like surgery, pregnancy, and all these conditions, you might need transfusions. Apart from that, you don't need regular transfusions. But whereas in a thalassemia major, these patients need regular transfusions and they are completely transfusion dependent. So that is the reason why this is very important to understand. And the moment you go about the mild forms or minor forms, typically these milder forms we tend to call it as something called thalassemia minor or a thalassemia trait. So whenever you call a thalassemia minor or thalassemia trait, first of all the patient will not have any clinical feature and the patient will be completely asymptomatic. No clinical features of thalassemia will be there. Patient will be completely asymptomatic. There can be some laboratory abnormalities. For example, the patient may have increased RBC count, very common. Especially in a beta thalassemia minor, increased RBC count, patient will have microcytic hypochromic anemia. They have, very reasonable microcytosis will be there, but RBC count may be increased. In all these settings, these are some of the examples, but apart from that, you can't, very difficult to diagnose a thalassemia minor. For example, in thalassemia minor or trait, you can diagnose an HB electrophoresis. Remember, HB electrophoresis is very important in diagnosing a thalassemia minor, especially a beta thalassemia minor. If you want to diagnose a beta thalassemia minor, your HB electrophoresis will be useful, where HbA2 will be more than 3.5%. This is the trademark for a beta thalassemia minor to be diagnosed in HB electrophoresis. But whereas if you take an alpha thalassemia minor, the HB electrophoresis can be completely normal. So your alpha thalassemias cannot be diagnosed by HB electrophoresis also. So it's very difficult to diagnose. Based on genetic mutation analysis only you can diagnose, otherwise it's very difficult to diagnose. But whereas in a major and an intermediate, always HB electrophoresis will be abnormal. You will have some findings which I will tell you in some time what are the findings you will get in general. So these are some of the things you have to understand. First, thalassemia major, thalassemia intermediate, clinical features overlap, but what differentiates them is the transfusion dependency. Major is transfusion dependent, whereas minor is not transfusion dependent. Whereas minor, the patient will not have any clinical features at all in the first place. They are completely asymptomatic. Only some hematological parameters may be helping you to diagnose a minor or a trait. So otherwise it's very difficult to diagnose a minor or a trait. So we have some additional things also, laboratory abnormality in the sense, for example, the beta thalassemia minor, which I'm only telling an overview now. Beta thalassemia minor can be diagnosed by two important indices. One is called Menzel's index. Second one, we have something called Nestroft. That's called naked eye, single tube, red cell, osmotic fragility test. So you can diagnose by any of these methods, which we are anyway going to discuss in the subsequent minutes. So these are the clinical classification: major, intermediate, and minor. Completely clinical. I have not told anything about like your laboratory parameters as such till now. So now when we go for the genetic classification, and one more thing I didn't tell you, where I told you severe forms you can get with alpha as well as beta thalassemia, intermediate forms also you can get with alpha and beta thalassemia, mild forms also you can get with an alpha as well as beta thalassemia, which means it's not like you will get only severe forms with beta, mild forms with alpha, nothing like that. Anything can produce any kind of picture in the clinical presentation. So clinical presentation will only tell you the patient might be having a thalassemia and whether it is severe, mild or intermediate, but what is the underlying problem, whether it's alpha or beta, can be diagnosed only based on your laboratory parameters, which I'll tell you in some time. So if you ask me about the genetic classification of thalassemia, whenever you ask about genetic classification of thalassemia, before understanding genetic classification of thalassemia, you have to know what do you mean by homozygous, what do you mean by heterozygous, and what do you mean by compound heterozygous. So first, let me tell about what do you mean by homozygous. The moment you call about homozygous means, first thing you have to tell what is an allele. An allele is a combination of two things. One, genes that come from the mom, so which means I can write gene here and put an S here, which means for a particular trait. We are talking about a particular trait. For a particular trait or a particular character, for example, blue eye is a character. You might have multiple genes for a blue eye character. So trait is what we equate to an allele, not the genes. If it's a particular single gene causing the blue eye, that single gene you can call it as a trait, and single gene can be equated to an allele also. So in general, allele means a trait. I mean, there might be multiple genes that giving rise to a particular trait and hence a particular allele. So you can't really tell that only one gene is responsible for one allele. So that is the basic difference between allele and a gene. So you have gene from the mom and you have a gene from the dad. So, or you can write something called genes also, you can call from the dad. So both together gives rise to a particular allele, and that particular allele forms a particular trait. So that particular allele gives rise to a particular trait, and this is what is happening. Suppose this gene could be single or even cluster. A lot of genes could be there. Two or more genes also could be there. Similarly, dad's genes could be a single gene or even a cluster of a gene. For example, best example for a single gene forming, like mom and dad's is beta. Beta, you have only one gene inherited from both the parents, which means only two beta genes are there. But if you ask me about alpha genes, there are two alpha genes inherited from mom and dad. So two from mom and two from dad. So that is completely different. So it could be anything. So this is the basic difference between allele and like gene and a trait, and all these things you have to understand. So the moment I call about homozygous means you have same mutation in both dad as well as the mom. So which means you are going to have the same mutation in dad allele as well as your mom's allele. So mom's allele and the dad's allele both are going to produce same mutation. So I can write alleles here, sorry for that. So alleles, it's not a single allele. Obviously alleles will be two. So particular character comes from both the father as well as the mother. So alleles. So two alleles are there. So your mom gene or allele is also mutated, and your dad's gene or allele is also mutated, and the mutation is the same in both mom as well as the dad. You have the same mutation in paternal as well as maternal allele. Paternal as well as maternal allele. Remember, the allele may be single or it may be a cluster of genes. So in simplistic terms, you can equate this allele to a gene also. You can remember like same mutation seen in both the genes. So in this condition, this is what we call it as homozygous. I'll tell you the examples. The moment you call heterozygous, what do you mean by heterozygous? Heterozygous means you are having mom's gene, you are having dad's gene or allele, and one is mutated and the other one is completely normal, which means this is what we clinically refer to as something called heterozygous. So which means one is mutated, one is normal. That's what we call heterozygous. And what do you mean by a compound heterozygous? Compound heterozygous. The moment you call it as a compound heterozygous means you have a mom and you have a dad gene. For example, let us assume the dad's allele or genes are mutated, and the mom's allele or genes are also mutated. But why I put different color, one in pink and one in green, is both are completely different mutations. They are not the same. Both are completely different mutations. This is what we refer to as something called a compound heterozygous mutation or a compound heterozygous variant. So classic example, if you ask me a homozygous mutation, I can tell you, for example, if you have a HBSS, which means you know very well, normal, this is a classical homozygous mutation. If you have a HBA, typically the patient is having something called HBA, which means both the hemoglobin genes are made of hemoglobin A into 2. So which means both mom side they inherit hemoglobin A and dad side they inherit hemoglobin A as well. So this is a normal thing. But in sickle cell disease, you might inherit from mom also you might inherit a sickle gene, and from dad also you might inherit a sickle gene, which means it's the same mutation happening. So this is a typical example of a homozygous. Then what do you mean by heterozygous? I can write something called HBAS. I'm going to call it as heterozygous, which means if you ask me from mom's side, for example, it is HbA, that is normal. It's the normal adult hemoglobin that is inherited, which is a normal thing. But on the other hand, if you see the dad's side, it could be from the mom's side also, just for understanding I'm telling you. From the dad's side, if you see, they are inheriting HbS, sickle hemoglobin. So that is the reason why this is heterozygous. One is normal, one is mutated. So, but what is common heterozygous? If I write an example called HbS beta, so which means here you have both the genes mutated. So from mom's side, you have inherited HbS, and from dad's side you have inherited again a mutated gene, that is beta thalassemia. So which means both are mutated, but they are different mutations. So this is what we refer to as something called a compound heterozygote. So with this understanding, this is a very basic thing to understand about the thalassemia genetics, because why it is very important to understand the beta globin chain genetics, because I told you already in the last video, it is one of the first genes to be, to see in a human genome project, to delineated by humans, and that is the reason each and every nucleotide was sequenced in a beta globin gene for the first time. So that is the reason why this beta globin gene is been so important in all the genetic books. That is the first mark where we have started understanding how a gene works, what is a promoter and what is transcription facilitators, and all these things we have Tata box, everything we have understood by beta globin gene analysis only. This post-translation modifications, mRNA splicing, everything we have literally understood from beta globin gene for the first time. So that is the reason why this is important to understand in the first place. So once you have known about all these factors, so let us move on to the real genetic classification. First one, let us discuss about the alpha thalassemia. So let me put the small table, a homozygous here. Let me put a heterozygotes here. So you have alpha thalassemia for that matters, and again alpha thalassemia you can have two types of alpha thalassemias. One is called alpha 0 and second one is called alpha plus. So what do you mean by alpha 0? Alpha 0 means I'm talking only about one particular allele. So one allele means alpha 0, one allele, but alpha 0 means, for example, one particular allele contains two genes, isn't it? So two alpha genes. Alpha 0 means both are abnormal, which means both are deleted, so that absolutely no alpha chain synthesis is possible from that particular allele. I'm not talking about both alleles, from that particular allele or from that particular gene cluster or a gene, no alpha chain synthesis happens or no alpha chain synthesis is possible. Which means since alpha thalassemia is mostly due to gene deletions, the only way to get this is both the alpha genes from that particular allele should be deleted. I told you one particular allele of alpha chain has two alpha genes, and you inherit two from mom and two from dad, so you have four alpha genes. So one particular allele means from mom means two alpha genes you are inheriting. If that particular allele should not work at all, means the entire both alpha genes from one particular parent should be deleted, then only you will be resulting in alpha 0 type of a particular allele. So suppose if it's alpha plus means there is synthesis of some alpha chains. Some alpha chain synthesis still happens, which means to get that, since alpha, thalassemia is due to gene deletions, to get that if you take this is the mom's allele, typically only one will be deleted and one will be completely normal. So, in the sense, I'm not talking about heterozygous. Heterozygous means only when you go to the next dad's allele also, then only whether it's normal or not, then only you can call heterozygous. But if you have in the same allele, to get some alpha chain synthesis, only one should be deleted and other should be normal. Then only you can get from that particular allele, it's mutated, that allele is mutated, but still that genes are mutated, but still some alpha chain synthesis is still possible from that mutated allele from a mom or a dad, anyone. So this is what we call alpha plus. So when you call alpha 0 homozygous, what it means? So which means both mom and dad, which means mom also should have alpha 0 dad also should have alpha 0. So which means you are inheriting both, no change in this from both the alleles. So what is this possible? Which means you are inheriting 2 genes from mom, deleted, 2 genes from mom, which is deleted. At the same time, inheriting 2 alpha genes from dad that are also deleted, which means you can indirectly write this as 4 gene deletions. That's what is going to happen. So this 4 gene deletions is the result of homozygous alpha 0. The moment you call homozygous alpha 0 means alpha 0 means all 4 genes are deleted. Both the genes from mom also deleted, alpha 0. Both the genes from dad also deleted, that is also alpha 0. So alpha, no alpha chain at all. This is what we call 4 gene deletion. How they are going to present this 4 gene deletion? I already told you they are going to present death in utero, which means very severe form. The reason for this is, I told you, in the fetus, one hemoglobin is very important. That is called something called a hemoglobin F. And if hemoglobin F contains alpha chain and gamma chain, I already told you any chain, alpha, beta or alpha, gamma, both these things should be in balance and exactly equal to 1, and the cell regulates very nicely all these things. So, but in this condition, since there is absolutely no alpha chain at all, there will be only gamma chains will be produced, and these gamma chains can tetramerize and they can produce something called gamma 4 tetramers. And this gamma 4 tetramers is what we are going to call it as something called hemoglobin bards. And the problem with this hemoglobin bards is because this is only made of gamma chain. Remember, gamma chains are the ones that give that characteristic high affinity of oxygen to the hemoglobin F. Why alpha, hemoglobin A is having lesser affinity in comparison to hemoglobin F, because we saw in the hemoglobin oxygen dissociation curve, ODC curves also, where HbF itself will shift the hemoglobin curve, ODC towards the left, because it increases the affinity for the oxygen. The reason for HbF having increased affinity for the oxygen is the gamma chains, alpha and gamma. The gamma is the reason. But if all the 4 chains are made of gamma, then definitely you are going to result in something called very, very high affinity, because they are not going to release oxygen at all. So very high affinity, very much increased oxygen affinity, which means the tissues will go for hypoxia, which means they are not going to release oxygen at all in the tissues. Because they go for severe hypoxia of the tissues, they may go for something called high output cardiac failure, severe anemia, and they may go for hydrops fetalis. That is the reason why they die in utero. So they can go for something called hydrops fetalis. That is because of something called high output cardiac failure because of severe anemia. 2 reasons. This gamma 4 tetramers can itself cause erythrocyte instability and hemolysis and erythrocyte instability. Both can be produced by this gamma 4 tetramers. At the same time, this also has very high oxygen affinity, which does not release hemoglobin at all in the peripheral tissues, so which means it can result in severe hypoxia, high output cardiac failure and hydrops. So that is what is going to happen in homozygous alpha 0. Then come to the alpha 0 heterozygous variant. So what do you mean by alpha 0 heterozygous? Which means one is alpha 0, another one is normal, which means you know very well one should be normal and one should be mutated. That's what is happening. The mutated one is alpha 0, we have already told, then only you can call it as heterozygous. This is the definition of heterozygous, one normal, one mutated. But the mutated here, we are giving a condition that is alpha 0. So which means in this context, you can write it as alpha 0 means no alpha genes in that particular allele, both are deleted. At the same time, here it is normal, which means 2 alpha genes are normally there. Clear? So in this condition, how they are going to present is this heterozygous, which means this I can also write as something called 2 gene deletions. The moment I write as 2 gene deletions, they are going to be completely asymptomatic and they are going to be present as thalassemia minor or a trait, which I discussed in the clinical classification already. They are going to present as thalassemia minor or trait. And again, very important thing is hemoglobin electrophoresis tends to be normal also. Hemoglobin electrophoresis tend to be normal in these patients also. Why I am telling that point very importantly, because beta thalassemia trait or minor will have HbA2 more than 3.5, a very classic hemoglobin electrophoresis abnormality. But here you are not going to have any kind of hemoglobin electrophoresis abnormality. So this is 2 gene deletion. If we ask about alpha plus, and if the patient is homozygous, what will result? So which means homozygous means both are mutated, and we are giving a condition both should be alpha plus. Both alleles should be mutated. Alpha plus means I already told you only one will be deleted, one must be normal. Similarly, alpha plus means only one gene will be deleted, other must be normal. but you can see both the alleles are some way it is mutated. So both are mutated, so that's why it's homozygous. But if you want to develop alpha plus, one alpha gene in that particular allelic cluster at least must be normal. Then only you can result in alpha plus. Homozygous means both are alpha plus. So which means it's again similar to something called 2 gene deletions, and again it's going to result in the same picture, like the patients will be completely asymptomatic. They might have a slightly elevated RBC count and a microcytic anemia, but apart from that, HB electrophoresis also will be normal. Only genetic analysis can diagnose this, like similar to other heterozygous alpha 0, where I have seen another 2 gene deletion. It's going to mimic the same way. So which means both are going to present in the same condition only. They are not going to be any different. So finally, you have something called a heterozygous alpha plus. So what do you mean by heterozygous alpha plus? If you want to know about heterozygous alpha plus, which means one is alpha plus and another is alpha, which means one is normal and other is mutated. This is what we call heterozygous. But in the mutated, we have given a condition called alpha plus, which means in this one alpha should at least be normal. Then only you can get some alpha genes in this alpha plus, and the other one must be completely normal, which means it is technically equivalent to one alpha gene deletion. If you ask me one alpha gene deletion, how they will present is typically in a way called a silent carrier state. This is what we refer to as something called a silent carrier. What do you mean by a silent carrier? Silent carrier means peripheral smear normal, hemoglobin electrophoresis normal, completely asymptomatic, which means you can't diagnose by any hematological or clinical parameters. Not possible. Everything in this patient will be normal, including peripheral smear. At least in minor or a trait, you had some element of microcytosis and increased RBC count. But in this condition, you will not have any abnormality in the peripheral smear or laboratory parameters. The only way to find this is in the genetic testing. Apart from that, you can't find. Maybe you can, because you cannot do all this thing in all patients, isn't it? Because everyone will be asymptomatic, and how can you suspect? Only in patients of already thalassemic patients or already having alpha thalassemia known cases, their children, if they are having, can be screened for this asymptomatic silent carrier state, because they might transmit the disease in the future to some of their progenies. That is the reason in those conditions you can test for this mutation. Otherwise, there is no point in testing in these asymptomatic patients. So these are the importance about this alpha thalassemia I told you. But we have seen 4 gene deletions, we have seen 2 gene deletions, we have seen 1 gene deletion also, but we have not yet seen this characteristic 3 gene deletion. We have not yet characteristically seen this 3 gene deletion. So what do you mean by 3 gene deletion? 3 gene deletion typically results from a compound heterozygous mutation. This again it comes in here. This is a compound heterozygous mutation. So what do you mean by a compound heterozygous mutation? If you ask me what do you mean by compound heterozygous, the first one is like you should have a mutation. For example, one is alpha 0 and another is alpha plus, which means from one allele you have no alpha genes in this. From another allele, if you have some alpha genes in this is actually both moms and dad allele are mutated, but both are showing different mutations. So which means typically this, characterizes this common heterozygous definition. So alpha 0 means no, absolutely no alpha genes are there. Alpha plus means at least one alpha gene is somehow missed, intact. So this is what we refer to as this 3 gene deletion, and this is going to result, this compound heterozygotes in alpha thalassemia, that is the 3 gene deletion, characteristically is going to result in a typical disease, something called as HBH disease. That is what we refer to as something called a hemoglobin H disease. So how this hemoglobin H disease is going to present? Hemoglobin H disease has problems during fetal life also, but it is not severe enough to kill the fetus. The fetus will be born alive. It's not, unlike 4 gene deletions. 3 gene deletions will affect the fetus, but they won't die in utero. Affect the fetus, but no death in utero usually. No death in utero. At the same time, they will affect the children also. They will affect the newborns also. Newborn and adults. Newborn and adults at the same time. So both can be affected. That is the reason why you can diagnose this condition at birth, most of them. Remember, beta thalassemias never ever present at birth. One of the very important alpha thalassemias, as I told you, only alpha thalassemias can present at birth. And the only alpha thalassemia that present at birth is HBH disease. Very important. They present at birth itself. They will present at birth with usually anemia, usually typically in the range of 7 to 8 grams per deciliter. Somewhat moderate to severe anemia will be there. At the same time, patient will be having a lot of other characteristic features of thalassemia, intermedia features, which we'll discuss in some time. What could be the clinical features of thalassemia intermedia? So typically this disease is going to present like a thalassemia intermedia, which means these patients are completely non-transfusion dependent thalassemia, but they will have clinical features of thalassemia. Clinical features of thalassemia will be there, but they are completely non-transfusion dependent, which means generally they present like a thalassemia intermedia, and they present at birth itself. They'll have splenomegaly. All these things are very common at birth. So why problem in the fetus? Because I told you in this condition, alpha, gamma, this is important for fetal hemoglobin. Alpha, beta ratio is important for adult life. In both these conditions, since alpha is significantly decreased in both these states, this gamma and beta, since it's relatively normal, they can form something called gamma-4 tetramers during fetal life. That is the reason why they have that anemia, hemolysis and all in the fetal life itself, but it's not manifesting as death, that's all. But still they do have this hemoglobin bards formation. That is, this gamma-4 tetramers is what we are referring to as hemoglobin bards. So these bards will be there. That is the reason why they develop anemia at birth itself. All this erythrocyte instability, hemolysis and all will be there at birth itself. At the same time, why this disease gets prolonged in adult life also is because this hemoglobin A also, because of relative excess of this beta chains, they tend to form something called this beta-4 tetramers. As the hemoglobin shift happens from HbF to HbA, they start producing, instead of gamma-4 tetramers, they will produce beta-4 tetramers. Again, that is going to cause the continuing anemia, erythrocyte instability and hemolysis. That is due to beta-4 tetramers, which will typically result in a hemoglobin called hemoglobin H. Very important. This hemoglobin H is the one in the peripheral smear is going to cause something called a golf ball cells. We have already seen this in the RBC inclusions. In the RBC basics we have seen this. They are going to result in something called a classic inclusion body called as golf ball cells. So if you just want to revise, so what do you mean by a golf ball cell? You can see one more time. So this is where you have this typical golf ball cell, where you can look like this dot inclusion bodies are HB, H. So these are HBH inclusion bodies, and these cells are what we refer to as something called golf ball cells. Very important point. So that's what you see. These are HBH inclusions. So very important. And remember, HBH inclusions can be stained only by supravital stain. Only by supravital stain. Supravital stains. You cannot stain this HBH by normal Romanowski stains. This GMSR right stains and all will not stain your HBH. There are two things you can remember. All inclusion bodies of the RBCs can be stained by supravital stains. Everything can be stained by supravital stains. Every single inclusion body can stain with supravital stain. But you have some important things. What GMSR right, that is this Romanowski stain. GMSR right stain is an example of a commonly used Romanowski stain. What GMSR right can't stain? What GMSR right cannot stain is your Heinz body. Heinz bodies and HBH disease. HBH. So these are the two things that your routine stains can't stain. Very, very important. Which means this Heinz bodies and your HBH can be stained only by supravital stains. But all the inclusion bodies can be stained with supravital stains. Similarly, there are some special stains for Prussian blue. You stain ringed sideroblast. We have seen already. This is initially itself I have shown. This is the ringed sideroblast. This can be better stained with Prussian blue. Similarly, these Pappenheimer bodies are also better stained with Pearl's Prussian blue stain. Apart from that, every single inclusion body can be stained with supravital stains like new methylene blue or brilliant crescel blue. But your Heinz bodies and HBH can't be stained by your routine GMSR right stains, which can be stained only by your supravital stains. Again, very important point. Again, investigation wise, this peripheral smear itself will give a clue, and genetic analysis is also there. And treatment wise, if you ask me, this 3 gene deletion, that is this variant of alpha thalassemia, treatment wise if you ask me, they generally need only occasional transfusions. occasional transfusions, which means only during crisis they need transfusions, which means this is a feature of a thalassemia intermedia. This is a feature of a thalassemia intermedia. That's it. So this is what is going to happen. So we have seen about homozygous, heterozygous, common heterozygous also, 1 gene, 2 gene, 3 gene, 4 gene deletions, everything we have seen. But we have not seen a non-deletional alpha thalassemia. This is the final on alpha thalassemia. There is something called a non-deletional type of a alpha thalassemia. The moment you call about this non-deletional type of an alpha thalassemia, so what do you mean by that non-deletional type of alpha thalassemia? Means very simple, that is the patient will have some other thing apart from the gene deletions. The most common thing and the simple and the best example for that is something called hemoglobin constant spring. So that's what we call it as HB constant spring, otherwise called as hemoglobin constant, because it was first identifying in a Caribbean region called constant spring. That's why the name came from the geographical area where it was first discovered. That's what we call constant spring. So hemoglobin constant spring, the moment you call it as hemoglobin constant spring or HB constant spring, what is the reason for that? If you ask me, normally you have an alpha gene. For example, if you have an alpha gene, the moment you have an alpha gene, you will have a promoter here in the beginning. Before the gene starts itself, you will have something called a promoter sequence. This is a common thing, and at the end of the exon, you will have a lot of non-coding regions also. In between you have a lot of non-coding regions. These non-coding regions are referred to as something called introns. And you have a lot of coding regions. These coding regions we call them as red put in blue. These are the coding regions which give rise to the actual protein. These are called as exons. So I'm telling just as an example. So you have a lot of exon, a lot of introns and all these things, and finally which will be terminated by a stop codon at the end. And actually the things will continue after that. I mean, DNA is something that is going to continue. So stop codon, it ends. And where the transcription will start is here, and it's going to end here, which means it's going to start at this point, which is going to give rise to introns, introns, and exons, and finally stops here. It has to stop here ultimately. That's it. Which means the stop codon will tell you the mRNA transcription should stop at this point. So which means the transcription of the gene at this point will stop. For example, if you take this is the alpha chain mRNA, I am drawing only hypothetical, not the exact alpha chain. So this is an alpha chain mRNA for that matters. So what if your stop codon, I mean because of some point mutation, for example if you have an UAG, which is an example of a stop codon, instead there is a point mutation and changes to UGG, which means what is going to happen is you are not going to end with the, like in this condition, you are not going to stop here, which means the stop codon, because the point mutation, it has become a sensing codon. It becomes a sense codon, which means your transcription will not stop at this point, and the transcription is going to continue till you encounter the next stop codon. Till you encounter the next stop codon, till the next stop, it's going to continue just like that. So now what is going to happen is this mRNA transcription also is going to become increased, and the alpha chain mRNA is going to have this excess, mRNA. Additional mRNA, this is an aberrant mRNA. This is an additional mRNA segment will be there. This is an aberrant mRNA segment. And while it is getting translated in the ribosomes, the protein that is produced also will have a aberrant protein. Obviously, don't worry about that. These exons and introns, these exons will be definitely spliced and removed. I mean, these introns will be removed. This is called post-transcriptional modification. These introns will be removed by splicing. Obviously, there's no doubt about that. So you are going to get only the exon. Only the exons you are going to get. So which means, so for example, if you assume this is the real alpha chain protein, this is the real alpha chain. After removal of the introns, you have only the exons that is translated into amino acids. So which means this is the normal alpha chain. But what happens here is, here there is an excess alpha chain, excess amino acids in the alpha chain. That is because of the, continuing transcription. because of the stop codon mutation, point mutation in the stop codon that has changed to a sensing codon. Because of that, you have created this additional alpha chain, which is additional by usually 31 amino acids. This abnormal alpha chain. So this abnormal alpha chain, which has that excess of 31 amino acids, is what we refer to as something called a hemoglobin constant spring. So this is what we refer to as something called a hemoglobin constant spring. This is an aberrant amino acid. So what is the problem in this, sir? There is nothing. In alpha thalassemia, you can ask me, in alpha thalassemia, what you have told is the alpha chains will be decreased in number. But this is a point mutation causing an aberrant alpha chain. Here there is no decline in the alpha chain production. That's what you're thinking. So how can it be an alpha thalassemia? That's why, the key to understanding is this long mRNA, this aberrant mRNA. If you take this long mRNA, or this is more than, this is a big chain, isn't it? So this is not a usual alpha chain. So big chain, this is an aberrant mRNA, alpha chain mRNA, is unstable. Is unstable in the sense not all the mRNA will be translated into protein. Only 5 to 10% will survive. Remaining will get degraded because of the instability, because it's too huge. So because only 5 to 10% only will be translated into, they produce an aberrant or abnormal alpha chain, but still that is going to be translated in a very limited amount, only 5 to 10%, which means that abnormal alpha chain synthesis amount itself is decreased. Abnormal, at the same time, its synthesis itself is decreased. So this is what we refer to as, it's due to point mutation, it's not due to gene deletion. So it's due to point mutation. That is why this is something called as a non-deletional alpha thalassemia. That's what we call HB constant spring. For example, if you ask me about HB constant spring, you write HBAA. This is normal. So two things should be normal. So then if you produce HB SC, for example, one is A normal, and another is also HBA, because it's going to come in with alpha and beta. But if you write SC here, CS here, so this becomes an HB constant spring, which means this alpha chain, this is an HBA only, it contains alpha 2 and beta 2, but alpha contains this constant spring mutation, which means that is having an aberrant alpha chain. So that is why we can write as HBA constant spring. So here I am writing heterozygous. This is an example of heterozygous HB constant spring. But if I write HBA constant spring and HBA constant spring, this becomes a homozygous hemoglobin constant spring. And if I write HBA constant spring and another if I write beta, which means one is showing one hemoglobin is showing, one allele is showing a constant spring mutation in the alpha chain, another is showing a beta chain mutation. So in this condition, you can write a compound heterozygous forms also. So this is also possible. So some examples of how you can change the hemoglobin structure itself. So these are some examples. So depends again. Heterozygous typically comes with a thalassemia minor like picture. There will be usually no problem. Homozygous comes with generally a thalassemia intermediate like picture, which they are still. Here there is no clinical features of thalassemia, which means that is what we call it as a minor. And here they will have a clinical feature, but clinical features of thalassemia will be there, but there will be non-transfusion dependent thalassemia. Here it is highly variable, because common heterozygotes are generally highly variable, which means you can present with any picture depending on what is the mutation in the beta. It's a minor mutation or a major mutation, all depends on that. So these are some of the important things you have to know about the alpha thalassemia. So with this, we'll wind up the alpha thalassemia, but in the next section we are going to discuss on the important aspects of the beta thalassemia and what is hemoglobin lepore and what are the variants of the hemoglobin lepore in the next section.